Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, a few housekeeping points. Please make sure your mics are muted during the presentation. Also, we kindly ask you to hold your questions and comments till the end, at which time you may unmute yourself or put your questions in the chat box. Lastly, the CME credit will be displayed on the second slide and at the end of the presentation. Today's speaker is Dr. Barbara Slawski. Dr. Slawski is a professor of medicine and orthopedic surgery at the Medical College of Wisconsin. She completed her medical education and master's in biology at the University of Wisconsin. This was followed by her internal medicine residency at the Medical College of Wisconsin. Beginning in 2004, Dr. Slawski developed a multidisciplinary perioperative program that now delivers a universal standard of care using evidence-based protocols. This program includes a comprehensive preoperative clinic caring for over 17,000 patients annually and an inpatient co-management service within the section of perioperative and consultative medicine, of which Dr. Slawski was made the inaugural chief. She's currently the chief of hospital medicine and interim chief of the division of general internal medicine at the Medical College of Wisconsin. She also served as the chief of staff of the Rutgers Hospital, a level 1 trauma center affiliated with the University of Wisconsin. The programs and protocols developed by Dr. Slawski and her team are models of care locally, regionally, and nationally. She's a frequently requested speaker at national professional meetings and has authored multiple books and journal articles. Please join us in welcoming Dr. Slawski in her presentation on updates in preoperative cardiovascular risk assessment.
Good morning. Thank you very much for having me. So today I'm going to talk about preoperative evaluation from the standpoint of ischemic cardiovascular risk assessment. And we're fortunate to have some new guidelines to help us out today. The CME text number and phone number are below. I have no disclosures. So the first question we're thinking about preoperative evaluations is why do we even do them? And we have over 33 million patients annually in the United States who have surgical procedures, a little more than half of whom are inpatients. About 45% of those patients have multiple risk factors for having cardiovascular complications in the perioperative period. And about 1 in 33 of surgical inpatients suffer complications like perioperative death, myocardial infarction, or ischemic stroke. In addition to those patient-centered complications, cardiovascular complications are also associated with increased length of stay and cost, so they're a burden on the hospital system. Now, preoperative evaluation starts with a focused history. And I'm going to say this probably 3 or 4 times during this presentation, that there is no evidence that revascularizing patients before surgery improves outcomes. So this is not the goal of doing a cardiovascular evaluation preoperatively. So if we look at the history in the last 20-some years of cardiovascular evaluation, in 1996, the American College of Cardiology and American Heart Association released their first guidelines for preoperative cardiovascular evaluation. This was followed in the next few years by the development of risk calculators that we still use today in practice. So the Revised Cardiac Risk Index calculator, GUPTA, which is the Myocardial Infarction and Cardiac Arrest Risk Calculator, and then most recently, the American College of Surgeons and National Surgical Quality Improvement Risk Calculator. And I use all of these when I see patients, and we're going to talk about these as we go through. In 2014, the ACC updated their guidelines, and the European Society of Cardiology released guidelines that looked remarkably similar to the ACC guidelines. There really wasn't a functional difference between the two. But in 2017, we saw the Canadian Cardiovascular Society release some guidelines, and they were remarkably different than the American College of Cardiology guidelines. They included the use of things like biomarkers. They de-emphasized stress testing and functional capacity. And you're going to see why as we go through some of the evidence today about preoperative cardiovascular risk assessment. And then finally, just probably 8 weeks ago, the American College of Cardiology and Heart Association updated their guidelines, and that's what we're going to focus on today. So we'll start with a case. This is an 85-year-old man who comes to preoperative clinic planning a Whipple procedure. He's got pancreatic cancer, type 2 diabetes, high blood pressure. This patient's on glyburide and metoprolol, excuse me, and has a normal GFR, reasonably normal, controlled diabetes, and an EKG that's unremarkable. And this patient tells you he's inactive. He walks only to the mailbox because he has arthritis, but he never gets chest pain or anginal equivalents. And the surgeon tells you this patient could get medical therapy, chemo and radiation, but would have a better survival benefit if he underwent surgery. And the patient tells you at the same time he would defer having surgery if he felt it was very high risk, and he would undergo chemo and radiation instead. Now, I can't see the chat box, but what would be your next step? Would you do additional diagnostic testing? Would you do no testing and just go to the operating room? Or would you do additional testing and advise medical therapy? So giving this some thought, I would say there probably isn't a right answer in this case, but I would do number one, additional diagnostic testing, because there's an alternate to surgery in this patient, and doing additional diagnostic testing would be helpful to us in decision making. But what if this same patient was having cataract surgery? What would your next additional step be? Would you do testing, none, and go to the OR, or do additional testing and cancel surgery? So I would say the answer here is to do no additional testing and proceed to surgery. And the difference between these cases is risk, right? So the surgical risk between a cataract surgery and between a Whipple procedure are substantially different. So when we're thinking about preoperative cardiovascular risk assessment, we're assessing risk, and we're trying to think about what is this patient's risk of the surgery and the patient's underlying risk factors, and can we move that needle? And sometimes moving that needle is just informed consent so that the patient understands their risk and can make decisions about whether they're ready to proceed. Sometimes it's talking to the surgical teams who make different decisions about their surgical approach. And sometimes we can implement medical management that makes a difference in the patient's outcomes. When we're thinking about risk, though, the first thing we have to think about is what outcome are we risking, right? And this has changed in the perioperative landscape in the last few years. So most of us are familiar with this first concept of risk. It's MACE, or major adverse cardiovascular events. And this is cardiac death, non-fatal MI, cardiac arrest, myocardial and infarction. And in some literature, it includes pulmonary edema and complete heart block. But the rates of those events in the literature are relatively low. So if an article includes that or doesn't, it doesn't really affect the outcomes they're measuring. In some articles, we see MACE with 2 C's, which includes stroke. And more recently in the literature, we've seen these concepts of perioperative myocardial injury and then MINS, myocardial injury after non-cardiac surgery. And this is kind of a confusing part of the perioperative literature. Excuse me again. So let's talk about perioperative myocardial injury. So we see patients around the time of surgery have all these things that can increase their risk of having myocardial injury. They can have heart failure, kidney disease, anemia, right? And the definition of myocardial injury, this big peach circle here, is just an increased troponin in the perioperative period. It affects about 20% of non-cardiac surgery patients. MINS, or this myocardial injury after non-cardiac surgery, is a troponin elevation that's due to presumed myocardial ischemia, not just any troponin elevation. And then within that MINS circle is postoperative MI. So MINS occurs in about 10% of perioperative patients who have major elective surgeries. It's a myocardial injury. It's presumed ischemic. And even among patients who have MINS who don't meet MI criteria, there's an increased 30-day mortality rate. Among those post-op MI patients, about 30% of MINS is post-op MI, and they have an even higher mortality rate, as one would suspect. But interestingly, about 68% of post-op MI is asymptomatic. And if you think about that, it's because surgical patients might not even be able to report to you that they have ischemic symptoms, right? Because they've received anesthesia, they're getting pain meds, or they're distracted by pain at the surgical site. Both MINS and post-op MI are usually presumed due to coronary disease. And there's medical therapy that can use to treat even MINS in the postoperative period that's been associated with a decreased risk of 30-day mortality. Now, if you look at post-op MI, the rates have doubled in the last 50 years. And that's not because we're providing worse care, right? It's because we're better at detecting post-op MI. And that's why the mortality rate associated with that is decreased, because we're identifying MI that essentially isn't as severe as the ones that we identified when we only got them in patients with crushing chest pain in the postoperative period. So when we're thinking about preoperative cardiovascular risk assessment for that ischemic evaluation, we have essentially three key decision points in every pathway. One is the assessment of risk, and there are multiple available calculators. Another is functional capacity, and we'll go through this concept of METS, the Duke Activity Status Index, and other things like stair climbing. And then diagnostic testing, which historically has been focused on EKG, stress testing, and then whether or not someone needs to undergo left heart cath. But more recently is evolving into a focus on biomarkers. So I know you can't read this, especially if you're on a screen, you're going to see enlarged portions of this. But the American College of Cardiology encourages a stepwise approach to perioperative cardiovascular assessment. I think it's much more useful in the clinical environment than, for example, the European Society of Cardiology guidelines that were released a couple of years ago. So the ACC starts out by asking us, does your patient have cardiovascular risk factors, disease, or symptoms, and are they scheduled for non-cardiac surgery? So if the answer is no, you can proceed to surgery. If you have a 24-year-old who can run 3 miles every day and they have no symptoms, we don't need to move them through this algorithm, right? They're low risk and they can go to the operating room. The next question is, are they undergoing an emergency surgery? So just like above, if you have a patient who's got a gunshot wound to the abdomen, we don't all stand in the trauma room contemplating whether they need a cardiovascular risk assessment. We get to the life-saving procedure in the operating room. But if the answer is no to those things, then we get to, do they have an acute coronary syndrome, unstable cardiac arrhythmias, or decompensated heart failure? If they do, we manage those conditions. If they don't, then we get to what is their risk. So in the ACC algorithm, the definition of low risk is a combined surgical and patient risk of major adverse cardiovascular events that's less than 1%. Elevated risk is 1% or more. And the assessment of risk depends on the calculator that you use, and we'll go through that. So the ACC says we should use a validated risk prediction tool, and you might be asking yourself, well, which one should I use, right? If we go back to our case, we can see that our patient had multiple risk factors for adverse events. He was of advanced age, his gender gives him additional risk, the type of procedure, and then he has multiple medical comorbidities that import risk to him. So we can calculate his risk using some of those calculators that I talked about in a previous slide in the history of cardiovascular evaluation. And what you see is you get different results depending on the calculator you use. But if you look at this, all of these results, with the exception of this one I'll talk about in a while, give you an answer of more than that 1% risk. So why do we see this variability in risk, right, with these risk calculators? And it's primarily because the inputs and endpoints when these risk calculators were developed vary. So we'll see in the next slide some of the differences between this, and that's why there's lack of data supporting a single tool. So this is a busy slide, but we can see the three most commonly used cardiovascular risk calculators: the Revised Cardiac Risk Index. This has 6 inputs. They're discrete variables. You get a score of 1, 2, 3, or more. The Gupta calculator has some variables that are more continuous, and it has 5 variables. And you can go on MDCalc and use Gupta today. And then the ACS-NISQIP calculator has 21 inputs. And for example, if you go in to put in the surgical type, there are thousands, and you can actually pull the CPT code off the surgical posting, and it'll pull up the exact procedure the surgeon posted the patient for. So is there evidence that one of these is better than the other to use perioperatively? So this was an interesting study published in 2018 looking at exactly that question. So what this author did was looked at the original study results for these risk calculators and then restudied them in the same patient population. So ROC is essentially looking at the ability of a calculator to predict the outcome. So 1 would be perfect. It does it perfectly every time. 0.5 would be essentially random. So Revised Cardiac Risk Index was developed for patients who were in the hospital spending at least 2 nights, and it looked at inpatient postoperative MACE events. And you can see it was pretty good at that. It had a ROC of about 0.8. Gupta and ACS were developed looking at 30-day of major cardiovascular events, and they were also good at doing that. In this more contemporary study, the author looked at the ability of all of these calculators to do in-hospital and 30-day events. And what you'll see is RCRI wasn't quite as good as doing that as Gupta and ACS were for 30 days. So in my clinical practice, I don't rely on RCRI, except for a rule out for patients who have a score of 0 to say they don't have significant cardiovascular risk. Now, this was a relatively small study, but what the authors also found is all of these calculators were pretty good at telling you if a patient fell less than 1% or more than 1%. And you can see where the variability is in these patients that come above 1%, but it still appropriately separated patients into risk calculator or categories, so they were all pretty good at that. Now, you might have noticed when I put this slide up before that RCRI was listed twice. It was listed with a 0.9% and a question mark and 6% and a question mark. And the question is, why is it listed that way? Why do we have 2 scores for the same risk calculator? So RCRI was first published in 1999. And you can see the results for major adverse cardiovascular events based on scores then. And patients with a score of 0 had a 0.4% risk of MACE events and a 0.9% risk for a score of 1. And they didn't get above that 1% risk till they scored 2 or more. And then in subsequent years, additional data was published showing different results, where in 2013, Davis and colleagues published a 0.5%, and then suddenly, if your score was 1, you were above 1%. And then in 2017, Duceppe and colleagues published data showing that every patient was above 1%, regardless of their RCRI score. So if you think about 1999 and how we diagnosed postoperative major adverse cardiovascular events, it was basically in symptomatic patients, and we used CKs and CKMBs, right? And if you go forward to this study in 2017 by Duceppe and colleagues, these were high sensitivity troponins ordered every day postoperatively for 3 days in asymptomatic patients. So it's like we see in PE, where if you get CTs in every patient, you're going to find more PEs. Now, this might be clinically meaningful, right? That more patients have elevated troponins in the postoperative period, but it's not helpful if we're trying to risk stratify people into more than or less than 1%. So this is another reason I don't use RCRI in my clinical practice for this purpose. I'll note that MD Calc uses this later data. So if you open MD Calc today, all of your patients, even that 24-year-old that runs 3 miles, are going to calculate at 3.9% or higher. So let's go back to our 85-year-old who is planning a Whipple procedure. And let's talk about functional capacity. So this patient tells you he could climb stairs and he could play sports if his knees didn't hurt, but he doesn't do those things because his knees hurt. And you calculate his MACE risk as 4.7%. And there's an alternative treatment option to surgery. So the question is, what would you do? Would you do additional diagnostic testing, or would you do nothing and proceed to surgery? So I would still get additional diagnostic testing here. And I think this functional capacity part here is where a lot of people fall into this trap of patients telling you what they could do. And the American College of Cardiology makes a specific reference in their guidelines that the reason why someone can't perform exercise isn't pertinent. It's that they can do it or they can't do it in your determination of functional capacity. So if we look at the algorithm here and we look at the elevated calculated risk in our patient, we would get a 12-lead EKG. And I'll recognize that EKG rarely adds prognostic information beyond risk assessment tools. It is helpful as a baseline for your postoperative period if you get additional testing and considering goal-directed medical therapy. But then we get to this concept of, does your patient have poor or unknown functional capacity? And in the algorithm, the ACC says, do they have a Duke Activity Status Index score of 34 or less than 4 METs? Then in their text, they say that we should use a structured assessment of functional capacity, such as the DASI score. So we're all familiar with this concept of METs. I'm sure most people in the room have done this, where you ask a patient, can you walk 4 blocks? Can you climb 2 flights of stairs? Can you do heavy housework? And then this has evolved to this concept of using the Duke Activity Status Index. Now, notably in the algorithm, the ACC doesn't differentiate, they say DASI or METS. So let's look a little bit at why DASI has made it into the algorithm. And a lot of this relies on the 2018 study by Vijay Sundara and colleagues called the METS study. And this was a prospective multi-center study of about 1,400 patients who had major non-cardiac surgeries. They all had at least one cardiovascular risk factor and were 40 years old or older. And everybody in the study had a preoperative end-terminal proBNP value measured, and they had an assessment of functional capacity either with the DASI and with METS. So interestingly, the authors called the determination of METS in this study the subjective assessment of functional capacity, which you'll see later in this slide. And they also did our cardiopulmonary exercise testing, or CPET, which is the measurement of VO2 max. In every patient, they measured a daily EKG and a troponin for at least 3 days or until discharge, and they did 30-day and 1-year follow-up. And what they found was there was no association between that subjective assessment of functional capacity, or for METS determination, and any study outcome. And only DASI scores predicted their 30-day outcome of death or myocardial infarction. Now, if you look at some of the data in this study, I think it's pretty interesting. If you separate patients into who could and who couldn't do 4 or more METs, you can see that among the patients who could do 4 or more METs, there was actually a higher absolute risk of having a 30-day mortality and MI, or those patients suffered more of those events. And the same was true for 30-day mortality and MINS. If you look at what each of these parameters was associated with, you can see that that 4 METs determination in this study wasn't associated with any of the study outcomes. A lower DASI score was associated with both 30-day mortality and MINS, and the end-terminal proBNP was associated with MINS and mortality. And interestingly, CPET testing, which is that bike test where they measure your VO2 max, was only associated with moderate to severe complications in this study. Now, this study only told us that the DASI score was associated with perioperative MACE. We were all left wondering, well, what score should I use, right? It doesn't help me unless I have a cutoff. So there was a later study that was a nested cohort analysis of the METS study that specifically looked at this question. And the authors found that a DASI score of 34 or more was associated with a lower risk of postoperative death and myocardial injury. And you can see here that an odds ratio of 1 lower for every point patients increased above a DASI of 34. So we use DASI in our clinical practice. In our preoperative clinic we have for several years. It's actually integrated into our electronic medical records, so patients can fill it out online before they come. Admittedly, very few do, so we also give them a paper form they can fill out. And then actually you can punch it into either our electronic medical record or you can use online tools. This is what it looks like in an online tool like MDCalc. What I'll say is that the DASI score here of 10 points, like if you open an online tool, is not equivalent to the number of METs they actually saw patients could do in the METs trial. So if you use an online tool to calculate a patient's DASI, don't equate that to the number of METs estimation that they can do. I found that one of the problems we have with having patients fill out DASI scores, just like when we had them do subjective assessment of functional capacity, is it's just not cut and dry. So patients answer yes and no, they put question marks, they annotate the forms, and it requires a lot of clarification to be able to get a discrete answer for DASI. Now, I use DASI in my clinical practice, but I don't think that the assessment of METs is gone. And I still use this. But I think part of the problem with METs assessment is there were too many variables, essentially, that patients could answer yes or no to. And there's more current data specifically about stair climbing that's associated with adverse outcomes in the perioperative period. And this is an example of a study looking at patients who reported that they could or could not climb 2 flights of stairs perioperatively. And you can see that the patients who could not climb 2 or more flights of stairs had a higher risk of MACE than patients who could. So basically, I use DASI in every patient that comes into preoperative clinic, but you have patients where you know that something feels off. For example, a patient who circles they can only take care of themselves, but they're clearly functionally fit. They walked into clinic, and when you start talking to them, they go to the gym every Monday. So I specifically ask patients, do you climb 2 flights of stairs? When was the last time you did it, and how did you feel? So let's go back to this patient, our 85-year-old who comes into the preoperative clinic planning this Whipple procedure. And because there's more than one option for treatment, you decide to get additional diagnostic testing to assist with clinical decision-making. And the question is, what is your next step? Would you get an exercise stress test? Would you get an N-terminal proBNP level? Or would you get a dopamine stress echo? So in this case, I would get an N-terminal proBNP level. And we've been doing this in our clinic for about 5 years based on some literature that I'm going to show you as we go through these slides. So if you look at the ACC algorithm, after we go through low functional capacity, so a patient who can't do DASI of 34 or 4 METs, we get to this question, will further testing impact your decision making? And if the answer is yes, the authors tell us we can get an N-terminal proBNP or a BNP level, or consider a troponin. So with troponin, I'm just going to comment. I think troponin is very helpful as a baseline for the postoperative period. There's some limited evidence that troponin values predict adverse outcomes. I'll say that I've gotten troponin values in a stable asymptomatic outpatient in preoperative clinic. If you do that and your lab runs that test, at 2 a.m., be prepared for how you're going to manage that critical value that gets called to you in the middle of the night. You don't face that with an N-terminal proBNP value. So there are multiple studies that demonstrate that preoperative biomarkers are independent predictors of perioperative mortality, MI, and heart failure. I'm just going to show you a few of these to demonstrate why this has made the ACC algorithm. Now, this is a bit of an older study, but it's a meta-analysis of some of the older articles, about 15 studies and 5,000 patients looking at N-terminal proBNP and BNP and their ability to predict major adverse cardiovascular events in the perioperative period. And you can see overall that elevated levels predicted adverse events. Now, the issue with these studies is they had different values that they were using as cutoffs, and different time frames in how they measured them. So we needed more definitive studies. And we had some very good ones published about 10 years ago. And I'm going to show you this one specifically by Rodseth and colleagues, where they measured N-terminal proBNP levels and BNP levels preoperatively and found that a level of greater than 300 or a BNP greater than 92 was significantly associated with perioperative death and non-fatal MI. And you can see this was a relatively high-risk surgical population because even the patients who fell below that threshold had a MACE event risk of 5%. But look at the patients who had BNP levels and N-terminal proBNP levels above that threshold. Their risk was 22%. And older studies also show significant odds ratios. Now, more recently, the vision studies, they're all essentially developed the same way. They measure a preoperative level and they get troponin levels on postoperative day 1, 2, and 3 till discharge. This is a nested sub-study of the vision trial, about 10,000 patients ages 45 and older who had N-terminal proBNP levels measured pre-op and the troponins post-op. And here what you can see is any N-terminal proBNP level above 100 was associated with MINS and vascular death. And you can see between the threshold of 200, the difference in postoperative MI and all-cause mortality. So N-terminal proBNP is strongly associated with 30-day cardiovascular outcomes. Now, we for a while were actually using a threshold of 200 in our clinic for N-terminal proBNP. I'll say the ACC specifically discusses 300 because there's better data for that. Now, these are not head-to-head studies, but I want to talk about the positive and negative predictive value of N-terminal proBNP and stress tests for predicting major adverse cardiovascular events. So you can see, for example, a dobutamine stress echo. If you have a positive test in a preoperative patient, it's not very good at telling you that patient's going to have a postoperative major adverse cardiovascular event. But if you have a normal test or a low risk test, it has a very good negative predictive value of telling you it's unlikely your patient's going to have that postoperative MACE event. And the same thing is true for N-terminal proBNP. An elevated value is not very predictive of adverse events, but it has a very good rule-out value. So in our algorithm, once we get an N-terminal proBNP value, if it's abnormal, we're told to have a multidisciplinary team discussion about the risks and benefits of additional cardiovascular evaluation. If we decide to go there, the ACC suggests we get potentially an echo, and I'm going to talk about echoes in the next slides, and then consider non-invasive testing, either in the form of a stress test or a coronary CT. I'll note the echo here, when you read the text, is really related to the elevation of N-terminal proBNP and ruling out associated conditions, not necessarily related to ischemic risk. So in the ACC algorithm, the indications for echocardiogram are for heart failure, ruling out new or doing this for new or worsening heart failure signs or symptoms. For suspected or known valvular disease that's at least moderate in a patient who hasn't had an echo in the last year. And then for patients who have pulmonary hypertension that's associated with RV dysfunction. Now, I've already mentioned in regards to preoperative stress tests that they have a very poor positive predictive value. They're good rule out tests, but they can lead to unnecessary testing and delays in the perioperative period. And the goal of these is not to prompt angiography unless there's high-risk features. So generally, we avoid stress tests in low-risk patients or patients with good functional capacity. So if you remember in our patient, one of the options was a treadmill stress test. If you're ordering a treadmill stress test in a patient, you should think about going back to the algorithm and determining their functional capacity. Because if they can get on the treadmill and do a treadmill stress test, they probably have a good enough functional capacity to avoid that. So what about coronary CT in preoperative evaluation? So there are several studies showing that coronary CT and coronary artery calcium scores for the assessment of cardiovascular risk in non-cardiac surgery are related to adverse outcomes. This is a systematic review and a meta-analysis of about 3,400 patients. And what you see here, so the blue bar are patients with no coronary artery disease on a CT, and you can see they have a relatively low risk of adverse events. These are patients with no or non-obstructive coronary disease. Here is where we see a statistically significant increase events in this green bar of single vessel obstructive disease. And then in multi-vessel obstructive disease, you see a significant increase in events. Now, this study also showed that coronary artery calcium scores are related to adverse cardiovascular events. One of the issues with this, though, is that we haven't seen a study that tells us a threshold. So we know that coronary artery calcium scores are associated with adverse events, but we don't have a cutoff that says, okay, at 58, you're okay, but at 57, you're not. We're not there in the perioperative literature. So I wouldn't suggest that as a criteria for your preoperative ischemic evaluation. So no multi-vessel disease on coronary CT in this study had a negative predictive value of 96%, which is pretty good rule-out capability. When we look at additional trials, like there was a vision trial using coronary CT, this demonstrated that coronary CT had marginally improved risk estimation above clinical risk scores, but it has a high rate of overestimation of risk, so we should be cautious if we're using this. So if we're thinking about revascularization in elective non-cardiac surgery, the ACC has some very specific guidelines for this. They say that it's for hemodynamically significant left main disease that's 50% or more, and severe multi-vessel disease associated with a reduced ejection fraction. And again, I'll say that preoperative revascularization has not been shown to reduce major adverse cardiovascular events or cardiovascular mortality in the perioperative period. So the goal of testing is to identify patients who would benefit from these interventions, even if they weren't undergoing that non-cardiac surgery. Now, what if your patient has already been revascularized via some sort of PCI? The guidelines also talk about how to manage these patients, specifically in regards to dual antiplatelet therapy. So if they've had a balloon angioplasty, we should delay non-cardiac surgery at least 14 days. 30 days for a bare metal stent, and this isn't different from what we've seen in previous guidelines. And then if they had a drug-eluting stent, the guidelines specifically differentiate if they had an ACS or not related to the placement of that stent. and suggest 12 months if it's an elective procedure, a shorter period of time if it's not elective. I want to point out that this discontinuation of dual antiplatelet therapy can be confusing terminology, and there are clinicians who interpret that as I can stop both their clopidogrel and their aspirin, and that's not the intent when that terminology is used. These patients need to stay on some sort of antiplatelet therapy, like at least a low-dose aspirin, once they get to the time frame where they can stop their dual antiplatelet therapy, unless they're having a procedure like an intracranial procedure that would result in catastrophic bleeding if they remained on their antiplatelet therapy. Now, one of the other things I really love this about the ACC guideline is they talk about how to assess patients for MINS in the perioperative period. And in the text, they talk about who should get troponin surveillance postoperatively. And that includes patients with known cardiovascular disease, cardiovascular risk factors, and patients who are having high-risk surgeries. We've been doing this for about 5 years at our institution on some of our inpatients. I'll say that we had more restrictive criteria than the ACC does now. And what we saw was actually a decrease in troponin surveillance with an increase in the number of patients who actually met MINS criteria once we implemented our guideline. But the ACC says if your patient has an elevated troponin, you should do a history and physical and a 12-lead EKG and determine if they meet the criteria for the universal definition of MI. But if they do not meet the universal definition of MI, your patient has postoperative myocardial injury. And this takes us back to those early slides where we talked about the definition of MINS. And this question is this likely due to an ischemic process? And if the answer is, well, to a non-ischemic process, it's actually confusing terminology, I'm sorry. If the answer is yes, it's likely non-ischemic, this is postoperative myocardial injury without MINS. So you would look for your PE or other cause of that elevated troponin. If you think it's an ischemic process, this is MINS, and then you talk about how we diagnose and treat MINS, which includes outpatient cardiology referral and potentially escalation of medical therapy. I'll say there are studies that demonstrate that patients with MINS who have outpatient cardiology referral or cardiology consultation actually have lower 30-day mortality. And if they don't have optimized medical therapy, there are studies showing that the intensification of medical therapy in MINS patients is associated with a lower risk of MACE at 1 year. So to wrap it up, our top take-home messages from the ACC guidelines are that we should use a stepwise approach to the assessment of ischemic risk, time it carefully to avoid delays, and remember that we should use the same principles for preoperative cardiovascular evaluation that we use for non-surgical patients so that we avoid over-screening and over-treatment. We should use stress testing judiciously in non-cardiac surgery patients, and then consider this concept of MINS because it's associated with significant consequences for our patients. So I'll end here. If you haven't seen this website, it's non-proprietary, nobody makes a profit. It's called preopevalguide.com. I use this I think the best use of it in clinic is just to type in a med and it can tell you how to manage it perioperatively. So with that, I think we'll open it up for questions.
Dr. Slawski, good morning. Dr. Klapholz here, Chair of the Department of Medicine. Thank you for this really wonderful presentation. on the cardiovascular pre-op risk assessment and the implications of the findings and how to think about them, and in the post-op period as well. Really, I think this is so timely for all of us. So really thank you for this wonderful presentation. We do have a few minutes for questions. That's great. So I'll encourage folks to either put their questions in the chat or to raise their hand or just speak up. And maybe while waiting for that, lots of many interesting things. Perhaps let me just ask, the medical interventions, of course, for coronary disease have profound effects. Simple things, that are super important, like getting people's LDL down, hemoglobin A1C. In these risk scores, as they have evolved over time, to what extent are they stratified, or has there been an opportunity to stratify them by the preoperative intervention with medical treatment? So by patients' LDL, by their hemoglobin A1C, when there is time perhaps to intervene on that. Do we have any insight about, is there any insight about that?
Yeah, I can't see that the risk scores particularly take that into account. Although if you look at the American College of Surgeons, the ACS-NISQIP calculator, I'd say the nice thing about that calculator is it evolves over time. It was originally published with like 1.4 million patients, and it's continuously updated. So it doesn't become with new patients in their database. So it doesn't become kind of antiquated and stopped in time like RCRI or Gupta work. So it would take into account new therapies we're doing for patients and so on preoperatively. I'd say if you're thinking specifically about like how we treat lipids before surgery or the use of statins, there's individual articles, for example, on statin therapy in the preoperative period and the reduction of cardiovascular risk, particularly in high-risk patients and some intermediate-risk patients, but I don't know that it particularly plays into our risk scores.
Might be an opportunity. Other comments, questions? Sure.
Thank you,
Our
Dr.
chief friend, Dr. Bello, is a budding cardiologist.
Thank you, Dr. Slawski. So my question goes because as residents, we tend to see a lot of pre-op risk evaluations, both at the inpatient and outpatient. And the case you presented resembled so many of the things we see on a daily basis. So my question is, what if a patient is undergoing a high-risk surgery, like an intraperitoneal procedure, and has a medical history that also increased the risk for post-op complications? But this patient has pre-op biomarkers that are negative, and the functional capacity cannot be assessed from the history. What will be the best next steps in those scenarios? And then just a follow-up question, what if a patient with those characteristics has some sort of renal condition or renal disease that will impair the proper assessment of cardiac biomarkers? What will be the best way to navigate those issues? Thank you.
Yeah, so for example, our Whipple patient where they've got high risk for perioperative cardiovascular events, as you go down that algorithm, basically you assess the risk, it's elevated, it's more than 1%, his was almost 5. You get to the assessment of functional capacity, it's low, so you get to this decision-making point. Will getting more testing change my management? If it won't, then you should go to the operating room. If everybody says this is a terribly aggressive cancer, I would take the risk to do this, then there's no sense in getting more testing, right? Or like I said, if you're standing in the trauma room with a patient who's bleeding out, you're not gonna decide if you're gonna get an N-terminal proBNP. But the next step in the algorithm, if that's the case, is an N-terminal proBNP. And if it's below your threshold, you're essentially done. You don't need to pursue additional testing like a stress test. And at first that feels like, wow, really, I shouldn't be doing anything else. But if you look at the data, the negative predictive value of that N-terminal proBNP is as good as your stress test. It's very predictive that you won't have that adverse outcome. Now, renal disease and heart failure, BMI, they're all things that can affect that N-terminal proBNP. So like at our institution, we do have some exclusion criteria for using the N-terminal proBNP, in which case we would move to stress testing.
Wonderful. That's helpful. Thank you so much.
Other comments or questions?
I'll say
While we're
while
waiting, perhaps, sorry.
oh, I was going to say, while we're waiting, I would also say that one of the traps we fall into when we're doing preoperative cardiovascular risk assessment is only thinking about ischemic risk. And that's what we were talking about today. But you'll see that the American College of Cardiology nicely put into their new algorithm that you need to think about other things like heart failure and valvular disease, right? Pulmonary hypertension, even frailty, they put in there. Because even if you have clean coronaries and you have critical aortic stenosis, your cardiovascular risk is high in the perioperative period. And I think that's something that was missed in previous algorithms that is nicely pointed out in this one.
Yeah, that's a great comment for sure. And I think as population ages, it certainly becomes more and more certainly prominent and present. I'm curious to ask you also, to what extent do you, or let me just say, do you use the pre-op score to interpret post-op MINS and the need for earlier intervention? And I know all troponins are not the same. I mean, and the score identifies people are high risk regardless, of course, of the surgery or not. So again, the pre-op score that might be elevated might really mean a lot more to that MINS in the post-op, and intervening earlier in those folks might be a better thing rather than waiting to go to the kind of the outpatient visit.
Yeah, so it's interesting. If you look at the Canadian Cardiovascular Guidelines, they took the approach of if your patient has an elevated risk of MACE preoperatively, you should get an N-terminal proBNP. And if it's elevated, you should still go to the operating room, but you should screen for MINS in the postoperative period, because they recognize that revascularization preoperatively is not associated with a reduction in cardiovascular events. So that's kind of on the extreme side of it, I would say. Now, there's reasons that the Canadian Cardiovascular Guidelines are so different than others. The authors of those guidelines are the same people that published much of the N-terminal proBNP data and so on. So they interpret it a little bit differently. At our institution, basically, we have criteria in a guideline for who is high risk and who should get troponins in the postoperative period. I mentioned that the ACC actually does this now, but theirs is much broader than ours is in current state. It would be a lot of patients getting screened in the postoperative period. If we get patients postoperatively with elevated troponin values, we go through the history and physical, the EKG, make sure we don't have universal definition of MI. But we have an inpatient perioperative medical consult team who escalates medical therapy, calls cardiology if they think they need it, gets an echo if they think they need it, and then we do refer to the postoperative cardiology consult group.
Yeah, thanks. It sounds like you really have a very robust approach there in the post-op period. Just the interest whether one interprets the MINS differently based on the pre-op risk. Interesting. Thank you. Other comments or questions? Dr. Slawski, I think we're at time. So let me thank you for this really highly informative, instructive, and critically relevant review of the periop risk. It's something, as Dr. Bello alluded to, is with us every day, as it is probably around the country. So really appreciate you bringing us up to date on this. Thank you again for this wonderful presentation. Thanks everybody for joining this morning. I think we had a great turnout, and just wish everybody a great rest of the day. Thank you.
Thank you.